All right. Welcome, everybody. For those that don't know me, my name is Dave McClellan. I'm the program manager for the Merge Collaborative. We're one of the hosting organizations for the Maine Rural Healthcare Education Grand Rounds. And this month, we are just thrilled to welcome Dr. Jim Jarvis. Just to tell you a little bit about Jim's position and background, he's the medical director of clinical education for Northern Light Health System, home-based over at the Eastern Maine Medical Center. Dr. Jarvis serves as the DIO, and he's overseeing graduate and undergraduate medical education. He has nearly 30 years experience in medical education, including serving as at the national level as president of the Association of Family Medicine Residency Directors. And we'll say he has a unique passion for appropriate billing and coding, which brings us to, I really appreciate that last line, Jim. So without further ado, I'm going to hand the floor over to Dr. Jarvis. I'm going to go off camera, and when it's all done, we'll check back in with everybody. So thank you.
Well, there, I should have started sharing my screen. I hope that happened for everybody.
Looks great.
Very good. So we'll go ahead and get started. If I can get my slides to advance. There we go. Continuing education will be provided by Maine Health and Maine Medical Center. And so this is our accreditation statement. I do not have any conflict of interest or relevant financial relationships that I need to state. It would be great if I got paid for every single time I gave this talk, but I do not. So this is how you can claim your CME credits through Cloud CME, and there'll be a slide again at the end to kind of go over that as well. So we'll go ahead and get started. So objectives for today is that I hope to identify the differences between types of learners, because not all learners are the same, and nor are they treated the same from CMS and a billing standpoint. So then we'll understand what billing for things that learners can perform, and yes, you can bill for some of the things that they do, and then understand the way that learners can make providers more productive. So why should we have learners in our practice? Well, the first thing is paying it back. Every single one of us was involved in an education program at some point in our lives to get where we are, and somebody spent their time to teach us. And really, I think it's important that we continue to do that for the next generation. Recruitment of future practice partners. It is quite clear from the data that specifically for physicians, but really for all healthcare providers, that they practice within a limited drive time from where they trained. And in fact, for physicians, that's 100 miles. And with the fact that we do have 4 sponsoring institutions in Maine that do train residents and fellows, but all of them only come as far north as Bangor, and we know that 100 miles away from Bangor, we still have lots of places that need providers. And so it's a great way to not only really spend some time with individuals in a practice, but also, it really helps us in terms of the need that that learners have to be within a practice. And wouldn't it be great to hire a new partner who trained in your practice, because it decreases their orientation time? And so, when we look at across the state of Maine, almost all of our practices between now and the next 5 years are going to need a new partner. And wouldn't it be great to have somebody that already knows what's going on? And then there's the personal satisfaction issue. It really helps to I'm sorry, my slide got covered up there. Can you still see my slides okay?
Looks great, Jim. Okay,
good. Yeah, just something came across my screen. It increases the knowledge for you about your current practice, and so because learners just keep us up to date, they ask us questions that we need to find the answers for. And so all of that is a relatively good thing to do. But one thing I think is really important for today's day and age is that people who teach have a lower rate of burnout than those who do not. And I think it's because learners bring back that joy of medicine back to us. And I think for now, that may even be the most important reason for us to have learners within our practices. So what are our types of learners? So we have resident physicians and fellows, medical students, and then advanced practicing providers. And those are the topics that I'm going to talk about. I know some people might be on the line who teach nursing students and things like that, but I'm really going to focus on these 3 categories. And they're definitely different. They're different in the way that they learn. It's different in the knowledge that they need, but also they're different in the way that we can bill for their services. So for a resident and fellow physicians, Medicare pays for services in a teaching setting when the physicians, not the residents, personally provide the service, meaning that the resident is just standing in the room while you do all the work. But residents provide, but they'll also pay when the resident provides the service when the teaching physician is physically present during the critical or key service parts, and this includes procedures. And what it says is, it doesn't say that the resident can't do the procedure or that the practicing provider needs to do the procedure. It means that the practicing provider has to be in the room when the procedure is being done. And so I think that's something that often gets overlooked. Oh, if the resident does the procedure, I can't bill for it. Well, you can, as long as you're there for the critical and key portions. And then this last portion, I'm actually not going to talk about at all because this only pertains when the resident physician or fellow physician is in their home clinic. And again, I've seen some health systems get this a little bit wrong, thinking, oh, well, we can bill under the primary care exception. But truthfully, you can only bill under the primary care exception when the resident or fellow is in their residency, practice, and teaching programs. So that doesn't count for anybody else. So what about students? Well, Medicare pays for the services in a teaching setting. When students participating in and contributing to a billable service, they must do it in the physician or the resident's physical presence, accept systems review, and past family and social history. So really what this is saying is that Medicare will pay based on a medical student putting in a review of systems and past things like social history and family history. And I think that's something that, again, many health systems just do not recognize that and think that what a medical student does or another student does is not relevant, but that is not true. Actually, we can bill for the stuff that they add to it. So it may make a simple visit into a complex visit because they add some of that past history. Medical students may document services in the patient's medical records. So yes, indeed, they can, and they should be documenting in the medical records. And teaching physicians must verify all student medical record documentations or findings, including the history, physical exam, and medical decision-making. And teaching physicians must personally perform or reperform all billed physical exam and medical EMM decision-making services. They can verify student documentation in the medical record rather than re-documenting it. And that's the key here when we're talking about how they can be beneficial to us. They can do all the documentation. You just verify that it's accurate. It can save us a whole lot of time. So how should we document? Well, for residents and fellows, normal documentation with the signature, title, time, and date. So no different than anything else. And that's really what we have to do. For students, they need normal documentation with signature, title, time, and date. But there needs to be an attestation along with that. And so that attestation could be something like, hey, I'm Bob Boberstein, an MS3 who performed duties within the scope of my practice while also scribing on behalf of the provider, signed Bob Boberstein, MS3. So again, this is what a student would have to put in their documentation. For preceptors, what would they need to do? Well, their attestation can simply be the documentation recorded by the student or scribe accurately reflects the service I personally performed and the decisions made by me. Documentation regarding vitals, family history, social history, and review of systems was obtained by the medical student acting as a scribe in their capacity as a medical student. The remainder of the document was recorded as scribed, J. Jarvis, MD, FAAP. And so that's the actual thing that they can, that the preceptor would have to do for an attestation. Or they can do, I personally saw and evaluated and participated in the management as a patient. The physical exam by the resident physician was performed in my presence. All findings were discussed, and I agree with the plan as documented in the resident's note. And so that's for a resident or a fellow physician who's with you. So distinctly different. Why? Because residents and fellows, we can count what they do in terms of their physical exam and their determination of evaluation and management. For medical students, we have to do that independent. So how can students add value in other ways? Well, look for opportunities for students to care for patients clinically or otherwise. So find some way that they can be involved. Share the teaching responsibilities. Change your workflow to allow students to contribute before and during after visits, like altering your patient schedule. When I first started getting into teaching and I worked in the military, I actually was able to make my schedule very flexible so that at 8 a.m. I had a patient scheduled for me and my medical student had a patient scheduled for them. At a quarter after, I had another patient scheduled for me. By the time I finished that patient, usually the medical student was near done with their patient. And so then we had our discussion, and that really became my 8:30 patient. And then we started that same process all over again. I saw the exact same number of patients that I did on a regular day in the exact same amount of time, but my medical student got to see 3 or 4 patients independent of me, and then we went in to see them together as if it was just part of my routine. My patients didn't really care because they are actually kept on time for their schedule, so it wasn't like they were waiting around. I think that's the biggest way that you can have students and not lose your productivity. Engage students in panel management, meaning having them go through your panel and just to say, hey, listen, I just noticed that one of your diabetic patients hasn't been in over a year. Maybe they should come in now. You want me to schedule an appointment for you? Medical students and other students are really good at that. Involve them in community health and things that could be of good nature for them. Um, uh, let students participate in and even lead quality improvement activities. This is something students, particularly today's students, are really good at. They love finding out additional information about things and trying to find ways to improve upon it. Here at EMMC, we have had students who've done amazing things like, hey, how to improve vaccination rates for teenagers to make sure that they're getting their appropriate HPV vaccination, and doing kind of little things like that. Or one time we had students who actually improved the little kit that we used when we were doing minor procedures in the office, that they reorganized it so that it was in a way that just made it so it was much easier for the provider to either do joint injections or skin lesion removals or things like that. These are what they're great at. And then advocate for longer teaching relationships. Hey, you have some student that you really like and you want them to come back, or you want somebody from their school to come back. Be an advocate within your practice and within whatever system that you work with, that this was a great opportunity, not just for the student, but for you guys as well. So what activities can students perform prior to a visit? They can queue up orders in our EHRs, like preventative care, labs, and medications. In our institution, students have the ability to do this, and then we just have to actually sign off on those orders. They can do chart review for recommended follow-up. So have them the day before go through what your next day's schedule is and find out who didn't have their colonoscopy or their mammogram so that we can get those ordered in advance. They can actually go outside your practice and do some other things. So like say you have a patient that's in your hospital and they're going to come back and see you in follow-up for those really important post-discharge follow-up things. You can send the student to go and actually greet them and say, hey, listen, we're going to be seeing you back on Tuesday. And I just wanted to say hi to let you know that I was going to be involved in your care. And I want to know, is there any questions that you have before you come in for that follow-up thing? Oh my gosh, imagine what that tells to the patient. The patient was so important that you sent somebody to go to the hospital and learn more about them. They can help set the visit agenda. We all know that there's always those things that are those hidden agenda moments that happen in our practice. Medical students are really good at teasing them out. They're also really good at saying, hey, listen, I know the patient came in and said they had this, but I noticed in their chart they really haven't been followed up on these chronic disease things. Maybe that's where we should focus our attention. Like I said, they can review social histories for you and document that, and you can count that towards things. What can they do during the visit? Well, they can room the patient. They can take vital signs. Yes, they can actually act as your MA. And if you happen to be short in a day, it's great to have a medical student who can help you with those things. They can do screenings like developmental and mental health things. Again, similar things that our MAs often are doing. They can do paperwork prep, like start filling out that school physical form or the form for the Department of Motor Vehicles. All those things that bog us down in our workflow. Students are great at doing that. They can perform medication reconciliation. Again, something that we don't do very well from a day-to-day practice. They can do that for you. You then sign off on it when it's done. They can update problem lists. They can input orders. So those are all things that they can do. They can give immunizations. Now, before I let my students give immunizations in my practice, I have them sit down with either my nurse or my MA to make sure that they're doing everything appropriate. But again, this could be a time saver for you in your office. They can draw blood. Same kind of caveat. I want to make sure they can do it before they practice on one of my patients. They can identify patient education materials, print them out, give them to the patient, even discuss them. They can give common patient education talks, like things on constipation or URI treatment. That actually frees you up to go see the next patient while they're finishing that up for you. They can provide motivational interviewing around common topics. So they can actually get to the heart of whether or not your patient is ready to start thinking about smoking cessation or cutting back on their alcohol use or getting into mental health or anything of those kind of things. And they're really good at that. They like to communicate, and you should allow them to do that. And of course, they can document care in the EHR. Redocumentation is no longer required. And so I think that's the important thing that I often hear providers say was, well, basically, I have two notes in the chart. I have the one that the student wrote, and then I have to write a brand new one. That is absolutely not true. If they act as a scribe, and as long as you are attesting to the fact that you have done all the key and important critical things, including redoing physical exam findings and E&M evaluations, then use their note for that. Just make sure that when you sign off on it, it is accurate. So what can the students do after a visit? Well, they can answer patient questions in person or through your portal or with appropriate supervision by the preceptor. So you're sitting there doing some portal messages, they can sit next to you answering some of your portal messages as well. They can call patients afterwards after a visit for a follow-up. So say you just told the patient, hey, listen, we're going to just call you in a couple of days to see how you're doing with that insulin change or to see if your cough is improving. Why not have your student do that for you? Again, they can provide that information right back to you, and then you can decide whether or not changes need to be made. They can do care coordination. They can actually accompany your patients to specialty visits, pharmacies, procedures, home visits if you want. These are things that they are capable of doing and that they can act as an agent for you and your patient. Imagine if you had a patient that had a complex history who's not a very good way of sharing, isn't very good at sharing that information, and you have to have them go see the specialist, and the patient or your student goes with them and accompanies them and can fill in all the gaps where your patient hasn't been able to explain what it is that you wanted done in that consultation. That's a great thing for both the patient and for your student. And they can make calls to coordinate specialty visits, social work assessments, community resources. They can be actively involved in all of those things. So how can visits be organized for student involvement? Well, be in the room during the entirety of the visit as the student takes the history, does the physical exam, and then presents to you. While the student takes the history, you be the scribe. You write the note and input the orders during the visit. This is a really good teaching tool for the student because the student then gets to know what they're doing right and what they're not doing well. You can certainly interject during the visit and say, hey, here's how I often use the otoscope. It sometimes makes it a little bit easier to see things than the way you were doing it just a little bit ago. And so I think there's that. Now, of course, this doesn't help with the time issue, right? Students do take a lot more time taking their history and doing physical exams. And if you're in there during that entire time, that slows you down, hurts productivity. So maybe just do it once in a while, or do it at the last visit of the day or the first visit of the day where you may have a little bit more flexibility. You can certainly join the student after the student is done taking their history and ask the student just to do the physical exam and present in front of the patient, encouraging the patient to let you know if there's anything that they'd like to clarify. This is an absolutely great and tried and true way of kind of doing these things. And then lastly, you can have the student observe you so that you can see what your process is for a visit and how you interact with your patients. And if they're observing, then they can actually write the note for you. Now, this is one that actually works out really well for our benefit because, again, we get to have a free scribe who actually has a lot of medical knowledge already and can usually write really, really good notes for us. For students, it gets to be a little bit boring after a while. So what I recommend is that if you're going to have a student over a period of time with you, whether that be 2 weeks or a month or a little bit longer, mix and match all of these. Even find a way to have these each of these in every single daily time that you have so that the student gets comfortable with all three of these methods. You feel comfortable with it. It'll also build a bond between you and the student, and they'll get a lot out of that. So how do we add to the efficiency of being a preceptor? Well, remember, students don't have to see every single patient. If you're seeing, the typical 8 to 12 patients in a half day, students don't need to do that. Maybe they only see 4 of those patients. That's okay. They're going to get a wide range of information, experience, and knowledge just from that limited thing. That's how most of us did it too. Teach in the presence of the patients. I often will go through and say to my patients, hey, listen, I have a learner with me today, and I'm going to do some doctor speak when I'm talking to them, and then I'm going to translate back to you in a way that you can understand. This is a great way. The patients then know that you heard what they were talking about because you're having this conversation with your student. They also think you're really, really smart because you seem to talk a different language than they've had. And then you can go back to the patient and include your student or your learner and the patient and yourself, and it becomes a really good opportunity. Get other people in your practice involved in teaching. Get your PAs, nurse practitioners, your nurses, your office staff and managers, and the students themselves involved in teaching. Students tell us time and time again that they're learning the the medical side of medicine, but they know nothing about the business side of medicine. And then when they become a resident or attending, they wish they had learned more as a student. Hey, have them spend time with your office staff and your office manager, learning about the business side of things and how we do things and how a practice is run. What does that do for you? It gives you a little bit of break so you don't feel like you have a learner with you all the time, but for the student, gives them invaluable information. Have your students prepare talks and educational material for staff or patients. They are whizzes at this. They just can't, most of them just got out of college where they wrote papers all the time. And they probably did a little bit of this as first and second year medical students or in the first year of advanced practice provider school. And in which case, just have them do this. Maybe there's a topic that you've been dying to talk to your staff about. You just haven't been able to get around to it. Have one of your students present that for them. So I'm going to finish up here with some resources, including some things that we have here at Northern Light, as well as a guidance here from CMS on billing and coding. And then, of course, our Merge Collaborative and our Collaborative for Building Maine, which helps to bring these things to you, and give a little plug out there for the clinical rotations that are available across all of Maine. And if you're interested in joining either the Merge Collaborative or the Building Maine Collaborative to bring students into your practice, just go and click on that clinical rotation site at the very bottom there, and that will actually provide for you information on how you can do that. And with that, once again, I'll just put up the slide here that if you wish to get CME activity for this, just text the unique activity code for this particular event to that phone number. If you haven't signed up for Cloud CME, there's information on how you can do that as well. That's on this particular one, and you can get your CME from Maine Medical Center, and we appreciate that Maine Health is able to do that for us. And then with that, I will open it up to questions, comments, or anything else that anybody would want, and I will stop sharing.
Thank you, Jim, for that presentation. I do encourage folks, please jump in with questions. I see Tom Gearin already is jumping with a hand up.
Jim,
Tom,
thank you for the talk. How would you, any tips for kind of orienting the student, your staff actually to your student or resident, so that they can kind of quickly onboard and trust them to do some of these activities?
Yeah, Tom, that's a great idea. So first, again, it's going to be determining what kind of learner you have, right? So if you have a resident or a fellow physician, very different. They can work a lot more independently, and kind of talk about the fact that they can write orders and they can do some things because they are under a training license and have that ability. You may want to check specifically with the policies of your own particular organization as to how much they allow resident or fellow physicians to do. But you can tell them they have a little bit more independence, and that's a good thing. And then if you have a medical student, PA student, nurse practitioner in there, I often try to start off the orientation with knowing what their level is and what their expectation is and what they want out of the visit. And I think that's a good thing. I remind staff that yes, indeed, students do have the ability to be able to do procedures and things like that. So yes, indeed, you can train them up on blood draws or doing immunizations and encourage them to bring students in when that happens. And then, of course, just be warm and welcoming and say, hey, listen, we have this great student. She's from Beale College and she's going to be doing this today. Or we have this great student from Unicom and he's going to be doing this. Or we have a visiting resident from Harvard University who's going to be working with us over the next couple of weeks. Let them know who these people are, what their level of education is, and I think that usually helps. And then have one of your staff, make sure that you show them around the clinic and where all the bathrooms are and where the break room is, as well as where they can find things in the office. So great question, Tom. Any other questions, thoughts, comments?
Want to give plenty of time.
Dave.
All right. All right. If anyone has another question as I'm talking here, please don't hesitate to throw that hand up. Well, Jim, Dr. Jarvis, thank you so much for that presentation today. Folks, as we head out, I want to make you aware of a couple things. Dr. Jarvis mentioned the iHELP-Maine platform. That is accessible to anyone free of charge in the state of Maine and beyond. It's accessible through two places, the Merge Collaborative website or the Clinical Rotations in Maine website, which is the Building Maine program that Jim talked about. They both have a link that says iHELP-Maine, a statewide learning platform. Please feel free to dive into that opportunity. Lots of great resources in there, no matter what your healthcare profession might be. Another great learning opportunity is going to be our upcoming Merge Conference. It is on March 28th. That's a Thursday and part of the UMaine Symposium for Biomedical Engineering. Give it a look. It's, again, linked on our Merge Collaborative website. If you haven't registered already, you are still welcome to do so. If you run into any issues, send me an email. Happy to help you take care of that. If you had already registered back in the fall before the date was moved and you cannot attend, just make sure to let me know or let the symposium know so that we're aware of the head count for that day. And lastly, I'd like to tease our presentation for next month. We have not made it an announcement on the website yet, but I'm happy to tell you today that our next presentation is going to be from Dr. Jason Hine of Southern Maine Healthcare. He's an emergency physician, and he'll be presenting time-efficient teaching. So you'll get some more details on that momentarily. We'll make sure it's up on the website, and we'll certainly let people know through the iHELP-Maine email address. You may have noticed every Friday, we like to send out an email about upcoming Grand Round opportunities. So I'll include some information on that on today's email and also other Grand Round opportunities from internal medicine or wherever it might be that's available to anyone in the state. And yes, I see Dr. McDermott, the slides be available. Yes, happy to do that. Jim has provided me with the slide presentation, so I'll make sure to put that up as well. In fact, Jim, I just want to put it back up on the screen real quick with that Cloud CME info, just so folks have it. We'll leave it open for a little while so folks have a chance to get it. Well, again, thank you, everybody. That will conclude our presentation for today. Grateful to have you. If you need those slides up, we'll leave it up here for a little while. If you need us to switch it around, you just let us know. Thank you so much and have a great afternoon.
Thank you.